Hello, everyone. Welcome to Module 1 for Introduction to Key Course Concepts. My name is Subia Idris, and in this session, I'm going to talk about the Module 1, that is Introduction to Key Course Concepts, from Introduction to Nursing Research for nursing students. So let's begin with the objectives. The objectives for this session are to list the range of knowledge required for nursing practice and explain the specific relevance of research knowledge. Describe the history of research and fundamental values of evidence-informed practice in a nursing context. The third objective is recognize the nature and purpose of evidence hierarchies and/or levels of evidence. So the first thing that I will talk is knowledge for nursing practice. It is not as simple as I'm saying here, because knowledge that is required for nursing practice is very complex. There are multiple reasons for this complexity. For example, if we reflect on our daily nursing practice, we encounter human beings, and each being is unique and different from others. Each one of us has different social circle and comes with different experiences. So then adding to these complexities, the next element is nature of health and illness. So every one of us has different health status and has different stamina and potential to deal with the illnesses that are surrounding us. Therefore, the knowledge to encounter all these complexities is also complex. But don't worry about this complexities, like how complex is the knowledge for nursing practice. I'll talk about in detail on diverse sources and types of knowledge that is required for nursing practice in a while on next couple of slides. So in 1978, a well-known scholar, Karpur, published Fundamental Patterns of Knowing in Nursing, and these patterns are well established and practiced in our daily nursing practice. So let's talk about each pattern in detail. The first pattern that Karpur presented is called empirics. So empirics means the knowledge that comes from research, and it means the knowledge that we get from the field of science. Empirical knowledge informs professional practice, not only from the common understanding of the scientific systematic assessments and observations, but also the subjective experiences of persons and the meanings they attach to those experiences. So second pattern is called aesthetics, the art of nursing. It's been defined as a nurse's ability to be compassionate, caring, and communicative. The third pattern, that is called ethics. So ethical knowing focuses on matters of obligations or what ought to be done. So ethics requires judgment about what to do and what not to do in our daily nursing practice. The last pattern and the fourth pattern is called personal. So personal knowing reflects the engagement between nurse and patient. It demands that a nurse know himself or herself so that he or she can approach the patient as a person, and then the nurse can build or form therapeutic relationship. And then based on that therapeutic relationship, the nurse can apply scientific knowledge to help the patient to overcome the sufferings. So these were the four patterns of knowing that are commonly practiced in our daily nursing practice. Now, this is very important to understand what Chin and Kramer in 2018, another renowned scholar, critiqued on Karpur's patterns of knowing he argued that each pattern of knowing is significant for nursing practice. We can't just focus or give importance to one pattern over the other. All 4 patterns make the foundation of nursing knowledge collectively. So nurses should not rely or see one pattern in isolation when they require knowledge in their daily nursing practice. So if you read the quotation on the slide here from Chin and Kramer 2018 on page 12, he quoted, and I'm paraphrasing it, if we do not examine knowledge even from one pattern as a whole, distortion in the knowledge will be produced. And this will lead to partial utilization of knowledge that will ultimately affect nursing practice. And definitely will also compromise the synthesis of knowledge that is required for nursing practice. So that was the important critique on Carper's patterns of knowing by Chin and Kramer. Let's talk about history of research in nursing, how it started and came. So in the first century of nursing, the intellectual dimensions of nursing remained implicit. Nurses were trained using an apprenticeship model. So what was that model and how it was practiced? So in that model, nurses were working for long hours at the bedside, and those hours were supplemented by some pearls of wisdom. Those were dispensed by medical doctors or physicians. But what happened by the mid of 20th century, it became very clear that effective nursing practice required a distinctive body of knowledge. So nursing interventions had gradually become independent of the physician's orders, and nursing required integrated knowledge of the physiological, psychological, and social dimensions of the patient. So by developing a program of research, nurses became assertive in utilizing their independent knowledge, and they were able to exercise power on their practice. Thus, contemporary nursing was started, and that requires professional and academic discipline of nursing. Nursing research developed gradually through the first half of the 20th century. It arose out of the desire to professionalize nursing and the belief that a profession needed a unique knowledge base to support independent action in the area of expertise. Now, as in the last couple of slides, we talk about the knowledge that comes from empirics, science, or research. Remember, the first pattern of knowing of Carper is empirics, so the knowledge that we gain from research. So now I'll discuss how relevant research knowledge is for nursing practice. What do you think? Do we need it all? Or we don't need it? We don't need this knowledge at all. Let's look at the goal first. Why nursing research? Because we need knowledge to advance nursing practice. This is an empirical knowledge. Yes, we definitely need this knowledge for our nursing practice, but it is important to recognize that the knowledge that guides nurses to be present to people, listen to their stories, and find out what matters to them in relation to their health experience and support their choices. That knowledge comes from the philosophies, values, and theories of the discipline, not from the empirical research or empirical evidence. So let's focus on the last bullet on the slide. We need empirical evidence, and it is useful for us, but it is not the sole or the most important source of knowledge for our nursing discipline. So in the context of nursing discipline, we need empirical knowledge, but that is not the only source of knowledge. There are other multiple sources of knowledge that we need to integrate in our daily nursing practice. Let's discuss what is evidence-based medicine. As you can see on the slide, it is defined as an explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. Now, how we get this best evidence available? Focus on the second bullet point. It integrates clinical experience and patient values with the best available research information. So evidence-based medicine was also called a movement, which aims to increase the use of high-quality clinical research in clinical decision-making. The last point, evidence-based medicine is not a cookbook. It is not a book with a lot of recipes. If you want to prepare a dish, you just look at the recipe and then use it. No, it's not like that. Evidence-based medicine requires good application that brings cost-effective and better healthcare. So I'll talk about a bit of detail of this concept. Evidence-informed practice. The movement of evidence-based medicine was started by R.K. Cochrane, a Scottish physician and epidemiologist. He published a book entitled Effectiveness and Efficiency in 1972, and he published it for medical profession. And what did he say in this publication? He published this book to use evidence from rigorous research for treatment decisions, not the knowledge based on the traditions or the beliefs or values. So why this idea came out and why he said that and why he published that, why he did that publication? So the idea of this publication was a contrast to authority-based medical practice. Because before this idea, what was happening, the medical practice was based on the traditional knowledge, on the values, beliefs, on the authority-based knowledge. But when the idea of evidence-based medicine came and Scottish physician did his publication, so then this idea came out that we need to engender greater trust in physician practice. We need to decrease the rising cost of healthcare, and we need to provide the best outcomes for efficient, effective, quality, and safe medical care. So that was the rationale behind bringing evidence-based medicine. Now, evidence-informed practice in a nursing context. We talk about evidence-based medicine and evidence-informed practice, but how this concept or idea came into nursing context. So evidence-based medicine was adapted as evidence-based practice by nursing and other healthcare professionals in 1990s. I hope many of you have heard or know about this honor society. The Nursing Honor Society, Sigma Theta Tau International Research and Scholarship Advisory Committee published a report in 2008. And in that report, they quoted, and here I am stating it, an integration of the best evidence available, nursing expertise, and the values and preferences of individuals, families, and communities who are served. So how the idea of evidence-based medicine or evidence-informed practice came in nursing context. So in nursing context, it is the integration of whatever the best evidence is available with nursing expertise and Most important, another element is values and preferences of individuals. If we are serving individuals, then the third element is the preferences of individuals. It could be families, it could be communities. So integration of all these three components is called evidence-informed practice in nursing context. In the next slide, I'll show you how the interrelationship or the integration of multiple elements we need to bring together for evidence-informed practice in nursing context. Let's see the next slide. This slide. So in this slide, you see, let me go to the slide here. You see multiple circles here, and you see different labels in each circle, but all the circles are overlapping. So that is the idea of evidence-informed practice in nursing context. So one thing that we talked about evidence-informed practice was best available evidence that is coming from research, empirics. So research evidence, then we will integrate the clinical expertise. After that, we will also look at the resources that are available at the healthcare setting. We need to look at the clinical state, setting, and what circumstances are where we are using the concept of evidence-informed practice. Another important element, we also need to integrate patients' preferences and actions or values, whatever they prefer and they believe. So the integration of all these elements or circles is called evidence-informed practice in nursing context. Now, this slide, it shows the evidence hierarchies. We also call it evidence levels or levels of evidence. So on this slide here, you see a pyramid here, and it has 5 levels, and each level has some specific studies. Now, these hierarchies or levels are assigned to studies based on the methodological quality of their design, validity of the studies, and applicability to patient care. So the level at the bottom here you see is called expert opinion. The level at the bottom has the lowest methodological quality. And as we go up, the methodological quality of these studies becomes higher. So they are more applicable in context of patient care. So at the top here, at the top of the pyramid here, you see it's experimental studies. So experimental studies has the higher methodological quality, the more strengths, and minimum weaknesses. As compared to the bottom, expert opinion has the lowest methodological quality. Now you see details here next to each level of hierarchies. This is just the extension or explanation of each levels of studies that are written here. You will learn the details of each level of hierarchies or the studies that are mentioned on each level throughout in your course. So don't worry about that. The pyramid that I showed you in the last slide, that was the levels of evidence or the hierarchies of evidence. So now in this slide, I'll talk about the nature and purpose of those evidence hierarchies. The evidence hierarchy allows us to take a top-down approach to locate the best evidence, whereby we first search for a recent, well-conducted systematic review. And if that is not available, then we move down to the next level of evidence to answer our question. So we rank studies based on the rigor, strength, and precision, and the validity of the research studies. Now, the interesting thing about this levels of hierarchies is that experts may disagree, so there is no exception. So they could disagree on the exact rank of evidence hierarchies. For example, some experts can say like, at the top is experimental studies and at the bottom is expert opinion. So any expert could say like, if experimental studies are at the top, it does not necessarily mean none of the other levels of studies could not be that methodologically rigorous. But most experts agree that the higher up the hierarchy the study design is positioned, the more rigorous the methodology, and hence the more rigorous the methodology is, it minimizes the effects of bias on the results of the study. So when there are minimum biases in the results of the study, the findings are more valid and applicable to patient care. So this was all about today's session on module 1. Next, I'm going to show you the reference slide. So these were the references that I have used in making the slides content. If you have any question or concerns, please post it. And thank you very much.